Okay,
There we
so
go. Wonderful.
as we're going along here, like I said, feel free to stop me at any point, questions along the way. If you need something addressed, just reach out at any time here. But so topic of presentation, orthodontics, what, when, and why. So kind of going through here and well, let's see if we can. There we go. So my background, some of this was kind of touched on. Did my undergrad at St. John's. They have a much more beautiful campus now than even much more than when I was there. Played a little soccer. Have a long line of history in terms of my family members going to St. John's. So it's kind of cool to kind of continue that. Went on to Creighton. Again, the school, it's amazing how things change over the years, but they've got a brand new facility down there now. Whereas when I was there, I was dealing with asbestos between floors and stuff like that. So again, crazy how things are kind of changing here. Continue that on to University of Iowa. Very lucky to have had the ability to go there, one of the top orthodontic programs in the nation. So met my wonderful colleagues. Some of them are in the picture here. One of them was getting married, so he's in the background somewhere back there. But really, really fantastic. Got a great education and wouldn't have had it any other way. And then establishing my practice. So I worked in the Twin Cities for about 2.5 years, kind of in the Shoreview, Maplewood area, and then took over a practice here in Sartell with a couple satellite locations in Little Falls and Big Lake. Um, Started that was always fun. On Christmas Day, after like 2 months of me owning, it decided to flood the entire building and all the fun jazz with that. So you kind of get into the thick of it real quick. So that was kind of my introduction to owning ortho here. And then my family. So this is my beautiful wife, Jessica, on the left. I have 4 kids, Charlotte, Xander, Bodie, and Remy is the youngest. They're all fun in their Halloween costumes. And so they're well, getting closer to about a year older here now. So they keep us busy, always running around. So what are we talking about? What do we do in orthodontics in terms of our specialty? Is it just moving around teeth? Are we just making people have a nice smile, look pretty? Yes and no. I mean, it's a little bit more than that. And so orthodontics, the full title of orthodontics is orthodontics and dental facial orthopedics. And or orthopedics, dental facial orthopedics is the movement of not just the soft tissue, but the hard tissue as well. And so that includes cheeks, lips, jaw structure, maxilla, mandible. And so a lot of things go into that. And then how are we going about changing these irregularities? Diagnosis, records that we're taking. So we're taking photos, x-rays, sometimes models, scans, CBCTs, three-dimensional x-rays in terms of diagnosing. Prevention is to essentially limit the negative effects that can happen without treatment. So what can we do with treatment to improve the soft tissue, hard tissue, the head, neck, facial features, so that we can put a patient in a better condition moving forward. And then treatment is how we're doing that, how we're doing it, what appliances are we using to accomplish this with their treatment. So we're going to keep things rolling here. In terms of our records, I'm just going to walk through. Can people see my cursor right now when I'm going over things? Yes? Okay. And
Yes.
so thank you. When we're looking at intraoral and extraoral photos, so inside and outside of the mouth here, lip projection is something that I look at. The nose, the chin, how it angles down to the neck, making sure lips come together when we're in a resting position, making sure the middle of the upper teeth are on with the middle of the face, making sure that the upper teeth and lower teeth kind of fill the corners of the patient's mouth. Look for crowding, look for any type of open bites or where those teeth are hitting, cross bites in the anterior. So all of those things, and that's just this patient that we're looking at right now, all of those things kind of start formulating a plan in our head as to what we're looking at. And then we transition that over to what's happening where we can't see it. And that's where x-rays are really important and come into play. And so in this x-ray specifically, we've got some wisdom teeth that are developing, and these don't correlate to this patient, so it's a little bit different. But we look at the joints. We want to make sure that that your TMJ, you hear a lot of people refer to as I have TMJ. Well, everybody has a TMJ. That's your temporomandibular joint. So everybody has a joint on both sides. Some people have TMD or temporomandibular disorder, where you have disorders of that joint. And so we look at those, and there's some different things that we can do orthodontically to help improve some of those symptoms. And sometimes we can't help that, and then we have a referral system as to where we can send things to make that happen. I'm gonna drop back here one more time. This X-ray down below is our CBCT. Okay, so our three-dimensional imaging. We take this for a variety of reasons. Sometimes it's impacted teeth that we're looking at. Sometimes it's airway evaluations, so monitoring what's going on here. Sometimes we have a large adenoid pad that's causing obstruction for patients, and they're having a really hard time breathing. And that can affect a lot of things. It can affect how their jaw develops. It can affect sicknesses and illnesses, not being able to breathe through the nose and filter that air through the nose, and we're getting a lot more through the mouth. So a lot of different things that we're evaluating when we're looking at those three-dimensional. And then this cephalometric X-ray over on the side essentially relates the upper and lower jaws together and the angulations of those upper and lower teeth. And so lots of different things that kind of go into play when we're treatment planning and trying to put together a diagnosis and a treatment plan for patients. So prevention, what are we preventing? Well, certain things we're trying to kind of treat, but habits are a big thing. So thumbs, fingers, a lot of kids have this, but a lot of adults have this as well in terms of tongue habits. I've had 40-year-olds sucking their thumb. So it just it varies from patient to patient. Guided eruption, opening up space for patients with excess crowding when we're young. So we're preventing the chances of impaction with that. That kind of goes hand in hand with early extraction. Sometimes we're taking out baby teeth to allow permanent teeth to come in a better place, and that will just put us in a better spot moving forward. Space maintenance. I don't know how dentally educated everybody is that's listening to this, but leeway space is a term that we use for a couple of our mandibular baby molars that sit in where these premolars are sitting right here. And when the permanent premolars come in, they're a little bit smaller than what the baby teeth are. And so sometimes just maintaining space can open up space in the future for our permanent teeth. And so that's kind of where space maintenance comes into play. And then orthopedic intervention, talking about how we can move the upper and lower jaws in a way where we can correlate them and get those to match up properly. Some of those treatments, okay? So going hand in hand with what we just talked about. This is an appliance that is used. It looks a little scary, almost kind of like a little Bane-ish from Batman with a mask on his face. It's just kind of on the inside of the mouth here. And so it's preventative. It's taking away that feeling that patients get when they put a thumb or a tongue between their teeth. It's kind of taking that enjoyment away because a lot of it's comfort when it comes to that. Talked a little bit about guided eruptions, early extractions of those teeth. These are just some different examples of space maintainers that we use. The example over to the right side is that lower lingual holding arch. And again, these are those areas where the premolars have come in this picture, but where the baby teeth are, that we kind of gain a little bit of space when we're talking about that. And then down in the bottom, different things that we use or appliances that we use to help with the orthopedic standpoint is expansion and headgear. Now, headgear was very popular a long time ago, has decreased its popularity quite a bit, but things have their place, and we do use headgear in the office. It's not super often, but this form of headgear that you see over to the side is called a reversible face mask. And that one is used probably more than any other type of headgear in my office, at least. And that's for patients that have a lower jaw that really sticks out and we're in an anterior crossbite. And so that helps out a lot and can prevent a jaw surgery in the future. And so really, really cool things that can happen with that. So we're going to jump into some treatment. I'm trying to throw lots of pictures at you. Hopefully you stay entertained while we're going through here. And if you have questions about any of these patients, just let me know. But this is an example of someone with a narrow upper jaw. We look at the back of the bite and it looks like it's doing okay, but the lower molars and the bottom are compensated and they're tipped in to the inside. So although when you're looking at things and it looks like the upper teeth overlap the lower teeth on the sides, when she ends up having braces in the future, those lower teeth end up uprighting into a better position. And now we're in posterior crossbite on both sides. So evaluating those things or knowing what to look for is really important with that. As you look at her x-ray too, you can see that her first molar is stuck underneath the backside of one of her primary molars. And you can see that in this picture here as well. And so she's got that impaction and it's starting to block off her premolar, as well as her anterior crossbite and the gum tissue that's getting really stressed down in the front here, okay? And so at 9 years old, we're looking to start an interceptive treatment. So again, before and after, you look at her lower front teeth down here. We had blocked out canine down on the bottom, some crowding on her lower left as well. We had a fully blocked out canine on her upper jaw, okay? And then we go to where we are now. You see the change in the shape of the arch, the space that was created on the lower, the proper upper and lower relation to those teeth in the front. And now we're not concerned in this early phase of making the back teeth fit together properly at this time. That's something that can come at a later point in time. But for right now, this is kind of a get in, get out, and make sure that those teeth have the ability to come in and the jaw relationships fit together so that she can continue to grow and develop in a proper way. Again, another 9-year-old here, narrow upper jaw. This time you can see the crossbite that's starting to form kind of in the canine and molar regions on both sides. That narrow upper jaw is then causing those upper teeth to contact right on top of each other. And when they do that, you're going to end up having a lot of wear of those teeth. Is it a huge concern when they're baby teeth? No, but if we don't get that jaw in a good relationship, it's hard for the lower and upper jaw to continue moving forward and growing in width and anterior posteriorly directions in a normal fashion to where we're not going to have issues moving forward with that. So again, moving forward to her final, the width of that upper jaw has changed quite a bit. I'm going to go back again. It's a little bit more V-shaped when you're looking at it here, hitting on top of those front teeth. And then going to it here, we've got those lateral incisors now in a good position. She's good. Back of the bite's lining up nicely to continue moving forward. And again, usually my treatments somewhere for these phase ones, somewhere between 6 to 10 months. A lot of them 8 to 10 months is what we're trying to shoot for. So again, really try to be short and sweet, accomplish what we need to, and then get out. And that prevents any negative effects that are happening from lack of hygiene and stuff like that at that age as well. Here's a 10-year-old. Again, here's a theme here with narrow upper jaws. Posterior crossbite, you can see it on his right side here. So the left side's not too bad, but you really notice it and you can see that it's changing his facial features. When he bites down, he contacts in a way that his back teeth don't fit together. So he has to shift his lower jaw to the right. Now, if we did nothing right now and we let him go for a few years until he has his permanent teeth in, we're essentially subjecting him to a jaw deviation. There's a high chance that his jaw on his left side is going to grow at a faster rate than his right side because he's constantly positioning his jaw in that way. And because of that, he's going to result in this deformation of that lower jaw, or discrepancy in that lower jaw, where that lower jaw sits off to his right side. Okay, and so this expansion is doing a couple things. It's widening that upper jaw, but also allowing the relationship to that upper and lower jaw to relate better. Okay, so in this picture, he's not shifting. The width of that upper jaw has changed quite a bit. Again, before and after. One last time, before and after. The spacing on the lower doesn't bother me right now. I'd rather have spacing than crowding. We can always deal with that in the future. So a couple examples here in terms of, we're going to kind of go down in a little pattern here. So first X-ray on top, you can see a canine's impacted mesially or tipped in, and the canine is not resorbing in terms of the baby canine on the top. So early extractions of those teeth can do a lot for us. No treatment is needed. We're talking about removing 3 baby teeth, so B, C, and H here, and then monitoring. This is, of course, over about 2 years. And you can see from the X-ray, now canines have come in, premolars have come in, and we didn't need to do any treatment. And so it's allowing kind of our makeup of those teeth and the nature of those teeth to try to find their way in. We're just allowing space for that. You can see that from the picture down on that lower left as well. Another example of those canines that are becoming impacted, the roots of the baby teeth that are not resorbing on both sides. So as permanent teeth come in, the root should start kind of wearing away, melting away. So when a baby tooth comes out, you don't have a big long root attached to it when they come out. And so the tooth fairy's not taking away a full tooth. It's just that little crown, that very top portion of that that they're going home with here. And so you look at the bottom too, this full baby canine on that lower right side still has its full root. Canine is impacted on the lower as well. And so getting rid of those, all right? This person also had some missing teeth down on the bottom. We're missing a premolar down on the lower right, and an incisor in the front. So some extractions, and then it allowed all those permanent teeth to come in here properly. And then we can deal with the alignment, how the teeth fit together again after that. This one is an example of how you look at this X-ray, and to me, when I'm looking at this X-ray, I'm like, this doesn't look too bad. Lateral incisors are working their way in. Canines are sitting to the side of those lateral incisors. This is all progressing very nicely. Vertical patterns, again, on the bottom. And so the problem is patient went missing, okay, for 3 years. Now they come back after not having regular follow-ups, and we have bilateral impacted canines. And when we get to that point where they're that overlapped over those lateral incisors, this now turns into a surgery. Okay, we need to have those teeth exposed and bond. And so this is where we work a lot with oral surgeons for situations like this, who will help get those teeth in a position to where they can put something on them, and then we can grab onto them and start working their way kind of back into position. Ectopic eruption, we talked about this here a little bit ago, but here is another example of how molars can kind of get, or permanent first molars, or 6-year molars can kind of get stuck underneath the back of one of our primary teeth. And so usually this is limited braces that can go on just on one side with a little spring, push that tooth back. Once that's back, that tooth is just fine. Patient can go on and things can continue developing nicely. So a little bit of fun here. My daughter likes to swim, And so we were just down in Hutchinson last weekend, and this was her first day. She had 2 days. She walked away with a few medals, so she was pretty excited about that. She did very, very well.
It's cute.
Uh, yeah, and then my son Xander, my second born, this is at a wedding around Christmas this past year. I had no idea this kid could dance, but it is kind of a shocker. I don't know if he's a closet dancer or what, but it all came out at this wedding. And there was at one point he was like up on his toes, like pulling a little Michael Jackson move. And so this is kind of an example of that. So I don't know where he gets it from. I obviously not from me, but from somewhere. So really cool to see. And then I decided to go and visit some friends in South Carolina, one of my colleagues from residency, and she decided to get pregnant. And what happened with that, or where I'm going with that is they were signed up for a half marathon, and I was going to watch. I'll run, but usually I run shorter distances. And she convinced me to run the half marathon for her. And so her name is still on that as finishing. But this was my first half marathon, so I'm slightly dying at this point. I think this is around like mile 8 or something like that. But beautiful. If you ever get the chance to go down to the coast of South Carolina, this was on Kiowa Island, so very, very beautiful. Um, what time do you guys have to wrap things up? Just so I know, so I'm working through
Yeah,
everything here.
Dr. Bell, we go till 1 and you can
Okay.
finish anytime between, anytime before 1 is
All right.
great.
Sounds good. Well, I
Yeah,
should be
thanks.
on pace here then. So when the American Association of Orthodontists, which is what we as orthodontists kind of follow, recommends initial exams happen at the age of 7. Now, a lot of people are like, well, that's so early. It is early, and a lot of times we don't do anything at that time. But what it does is sometimes it's me letting or informing patients, hey, you know what? You've got missing teeth, and we need to plan on what's going to happen in the future. Sometimes it's, hey, everything looks great. Let's see you in 2 years and let's just monitor how things are going. Maybe you'll never need treatment, but at least we can follow up with you and inform you if there's anything that we can do moving forward for you. So general and pediatric dentists are really key into this as to referring these populations over to us so that we can see them in a timely manner so we don't end up with those situations where we've got impacted teeth or blocked out teeth or missing teeth that we didn't properly adequate space for. Um, so we monitor these patients. Sometimes we treat these patients, and that's where this phase 1 kind of treatment comes in. And again, like I mentioned, somewhere between 8 to 10, and then they can be referred earlier. Sometimes it's for like a tongue tie that's affecting their palate development and how the upper jaw is developing, and we need to release a tongue tie. I will not release a tongue tie unless it is needed. I think that some like to do them just because there's an attachment, but I want to do it because of a reason. And so I want this to, if it's affecting how the arch is forming, if it's affecting speech, things like that. Other things, cleft lip and palate, hemifacial microsomia, dwarfism, any of these other syndromic patients that we see sometimes have to have treatment followed up with, or we have to develop a team at a young age in terms of moving things forward. And so then we're integrating dentists, medical professionals, surgeons, all of that at a young age so we can develop a plan moving forward so that we can kind of seamlessly transition from one point to the next.
Dr.
Again,
Bell, I have a quick
oh,
question
yeah,
for you about
please.
that last slide.
Yeah.
Is that relatively new? And obviously I'm dating myself, but it seemed like years ago children had or kids had braces on when they were 14, 15, 16 years old. And now like my granddaughter, like you said, she started treatment at 9. And
Mhm.
so is that a newer guideline or has that always been that way?
I'd say probably within the last 20-ish years, it's been more so. I would probably think of it more as preventative medicine has been, where how things have become more preventative. We're gonna try to intercept things so that same thing would go, or to caveat to this point that I'm trying to make, there's a lot less teeth taken out now than there was 20 years ago as well. And so you could come in and you're going to come in with a jumbled kind of mess on the top and bottom. And what's the best way to solve that? Well, extractions. Well, why are we doing extractions? Well, we didn't accommodate or make the space and allow the jaws and the teeth to grow together in a way that would prevent us from having to do that in the future. And so I think it's more of a preventative thing. And so you'll see some patients in that phase 1 and that phase 2 later on. And so if your granddaughter is in that phase 1 right now, don't be surprised if she's back into braces or Invisalign or something like that, spark aligners, sometime in the future here.
Perfect. Thank you.
Very welcome. So some of the things that we're looking at early ages and in adulthood, any type of crowding, anterior open bites that would suggest any type of habit, thumb habit, tongue habit, protrusion of the upper and lower jaw, so lots of overjet, distance between those upper and lower incisors, cross bites, posterior and anterior, and then complete class 3, so meaning that that lower jaw is really far forward. And I'll show another slide with that in there right here. So adults and adolescents, again, when? Gosh, there's so many different things. And here's a list of a bunch of different things. Malocclusions, class 1, 2, and 3. On the left side here, this is ideal, okay? Upper canine should sit behind the lower canine molar in this position. A class 2, imagine the lower jaw sitting back. And then in class 3, imagine that lower jaw sitting forward. And so those are the differences in terms of malocclusions that we have and that we look for. We talked about cross bites, blocked out teeth, transposed teeth. Essentially, if this canine decided to come in between these two premolars, that's called a transposition. It's coming in place of a different tooth in the wrong position. Some other things in here, some TMJ clicking, popping, crepitus. Crepitus is some kind of grinding of that joint where we have some adhesions in there that are causing some grinding. We talked about some of those craniofacial abnormalities with some of those syndromic patients. Airway issues, sleep disordered breathing. So you're talking about prevention and early treatment. Sleep disordered breathing is a big thing and a big topic in terms of airway that's been coming on the scene more so in the last kind of 5 to 10 years than it ever has been in the past. And then speech issues, narrow palates, tongue ties, malocclusions, all of those can play into those things. So one thing I want to touch on is sleep disordered breathing, because I take CBCTs, not just so I can evaluate airways, but they deliver less radiation than taking 2 separate individual x-rays. And then I can generate those separate x-rays from this image. But then I can also evaluate the adenoid pad. I can evaluate their sinuses. I can evaluate their septum. I can have discussions with them about how is their sleeping? Are you snoring at all? Are you waking up suddenly from lack of breathing? Are you having any type of mood swings? Are you having some attention issues at school? Are you having any type of bedwetting that is prolonged? Now, bedwetting can be normal until we're about 8 years old. But if we have things that are going on later than that, and sometimes before that too, sometimes there's a reason, okay? And it's not just developmental, it's we've got obstruction. We can't breathe, and so we're waking up at night. That's causing a lot of this tiredness issue, these attention issues that then come to school. And then what happens? We go to the medical doctor, and then they have to treat these patients because we're not able to normally function. And so then you see more and more kids being treated for like something like ADHD quite a bit. And so I'm not saying that everything we do can treat that. It's just something that has become more of a relation, and a lot of times opening up that airway can solve a lot of those problems. Some of those treatments, expansion, most people think of expansion as just being done in children, but since graduated from residency, we started to do adult expansion, and I started some of our clinical trials when I was at Iowa, and I've progressed and continued to do adult expansion today, and I'll talk to you a little bit about that here. And this is an example. So when you think of a normal expander, it's kind of like this, but minus 4 screws that are going through this gentleman's upper jaw, and a couple of these extra arms on there. And so at a young age, this line between these two teeth, or between this upper and lower jaw, is not connected. It's just kind of resting gently together, these two bones. And as we age, they intertwine more and more and more, almost like a little meandering stream between there. And it's harder and harder to get that to separate. So as an adult, we have to use some TADs, or temporary anchorage devices, screws for all extensive purposes here, in order to prevent a surgery. Okay. And so this allows us to get expansion. He's in posterior crossbite on this right side. After expansion, we created a large space between those upper front teeth. We can close that, but we've got that expansion that we need. If we would try to accomplish this surgically, we're essentially subjecting him to get put under anesthesia. Okay, and then this is tens of thousands of dollars in terms of a surgery to be accomplished in the operating room. And so if you are at my office, this is something where we're doing this for under a couple $1,000s in terms of this procedure, which is then non-invasive, less risk in terms of having any issues with that. And then this slim to none. I have not, knocked on any wood, had anybody with any type of adverse effects in terms of developing any type of infection or anything like that after a procedure like this. And so maybe that's lucky, or that's just, these TADs are very, very simple to be placed, and it really helps our adult patients that are looking for some of that airway expansion. Some of them, this patient was one that was prone to sleep apnea. Okay, and so widening that upper jaw, allowing for a little bit more nasal breathing can help with that. And the reason why I say more nasal breathing, think of like the palate as almost like the floor of your nose. And so if we're expanding that, that is helping to open some of those nasal passages and allowing for a little bit more of that airflow. And then when we widen and we allow that to come together, usually that upper jaw has a tendency to have a little bit more of a movement forward as we're changing some of the facial features when we're expanding some of that upper jaw. This is some of my team. We like to have fun. They're sporting some glasses that we have at our office that we give away and have our patients wear. I don't know what we did for Halloween. I mean, they wanted to be bugs. They wanted to be bugs and have like a fairy garden type thing. So I still had to like get into like a Robin Hood theme. And so I wanted to do something, but then my daughter got me to wear her set of wings. And so I was a fairy guy, I guess, is what I was. And then we do random things. This was something where our treatment coordinator, Katie, went and got a bunch of packages. Apparently there's a place in St. Cloud that you can go and just buy a bunch of like packages for $1 that Amazon couldn't take back. And you don't know what's inside them. You get what you get.
Oh.
And so I got a nice dress. And some other people got some other things, but we try to keep things light at the office. Why are we doing this? Okay, we're doing this to get the upper and lower teeth jaw structures to fit together, and this allows patients to bite, chew, have good nutrition, make sure that we're having a good diet. It allows them to have the ability to have proper speech, and then when things fit together, that's when we allow that smile to kind of come to fruition here, and we have self-esteem that increases. We have confidence that increases. And it's been proven that when your self-esteem and confidence increase and you have a nice smile, that your future seems brighter. You're able to go into jobs and have a confidence about you, a nice smile that might potentially allow you to get a position ahead of somebody else that might not have that ability. So here's a 15-year-old male. Look at this X-ray here on the right side. You can see how much overjet or distance he has between his upper and lower front teeth. He's got a very severe bite in the back, and it's very deep in the front. And so lots of class 2 correction here in terms of getting the upper teeth to come back, lower jaw to come forward. Growth is really important when we're talking about this. And then you see this transformation. So you see where those upper and lower teeth are now in relation to each other, the way those teeth come together. In the back, upper teeth falling down between the lower teeth. Again, before and after on that. Another example of an adult here, 40-year-old male, crowding on the top, crowding on the bottom, has issues with cleaning and maintaining things. Deep bite in the front. This is something that we did with aligners on him. It turned into a weight loss program for him too. And so not that he needed it, but he was very happy afterwards. In terms of his bite, I think he looks younger, okay, more youthful. You look at his smile and how everything comes together. He is more confident. His wife tells him that he's more confident. And it's something that's really helped. And some of these things don't have to take 5 years to accomplish. Some of this stuff is done in a year and a half, 2 years, in terms of getting everything to fit together. 10-year-old female with impacted canines. So bringing those canines into a better place, allowing room or opening up room for those. This was something that kind of happened over the course of a long time. She had premolars removed from these areas because she had that severe of crowding that we had to remove teeth. This is her at 11 years old with those missing premolars in those areas. A little bit of crowding on the bottom, still had a bunch of baby teeth, so we're waiting on a few things here. And this is where you can get to. So she had a great finish with premolar removal, and sometimes it's needed. We try to avoid it as much as possible, but a lot of times, if you've got that much crowding in there, it is a very good option in order to accommodate some space. So we talked about some syndromic patients earlier here. This is one young individual, great guy. Gosh, this guy is hilarious. Dwarfism is something that he was unfortunately blessed with here, so to speak. And so when we look at his jaw position, he is very severe. Like this is an upper jaw that sits very far back to the point where when we try to pull up his upper lip, you can't see any of his upper teeth. There's nothing there. Okay, they're hiding everything behind there. You see how far that lower jaw comes forward. So think about functioning. I can't move your jaw as far forward as what his is, but then try to function like that. Okay, try to chew things, try to speak, try to have a normal life, try to go to school and not get bullied and made fun of because of just your genetics, how you're made up. And so these are patients that I love. Oh yeah, go ahead.
Does
Was
someone
there
have
a
a
question?
question? No? Okay.
Oh, okay. Sorry. And so this was one that took many years and surgery, multiple surgeries to get him to this point. And so his upper and lower jaw now coordinate together. He will never be at the point where has an ideal profile, but oh my gosh, does this change his life drastically? He's able to function. He's able to, his speech has improved as an adult in his 20s here because of that. He's flying across the country doing internships in California and all this stuff, and he is confident now. The man is happy. He is in a very good position. So we're getting kind of close to the end here. Other things that we do in terms of confidence. Why am I doing this? We finished this young lady's treatment, and throughout the course of treatment, we had a little bit of issues with hygiene. Okay, so gum tissues got puffy. They started overtaking her teeth a little bit, and they started to appear smaller. So we gave those teeth and gum tissues some time to relax. After 3 months, we still had this same relationship in terms of how that gum tissue was. We're just not seeing as much of her teeth as we would like to see. And so talking about doing just some laser gingivectomy on those front 4 incisors. This is a couple weeks after on that right side. And then you look at her smile, okay? Huge difference in terms of gumminess that we're seeing on the left to that bright smile. Much more incisor show on that right side as well. And then this, we'll see if I can get this video to play here. Let me know if you can't hear this. Can you look okay? But can you guys hear this?
Yeah, we can hear it.
Okay.
That's not weird at all.
Not weird at all. You can't look at your teeth yet though, but you can get your hair where you want it. Are you ready? All right. Face down. You ready? Filled in? Let's do it. Let's do it. Take a look. Congratulations.
Oh my gosh, it looks so weird. My teeth look so big.
Look at that.
Looks so good.
They look beautiful.
Yeah.
And so this is why I do what I do. It's for reactions like this. It's for changing those lives. And hopefully you guys don't all look like this right now and
No.
to fall asleep after this thing. But hopefully that gives you a little bit of insight into kind of what we do, what we look at, some different things that we kind of treat along the way, a little glimpse into what I do. So
Wow.
anybody
awesome.
have any questions or
Yeah.
anything, comments?
Yeah, thank you, Dr. Bell. And we're
Yeah.
getting some thank yous in the chat. I just have a couple comments, but if anyone has any questions, they can. Oh, Elizabeth has raised her hand.
Oh, I could have waited for you,
No,
Nancy.
it's all right.
One question I had was with ectopic eruption.
Yeah.
Sometimes I've seen, like 3 and 14 jump, but when do you know that they won't jump, or what gives you that idea that they won't move over?
That's a great question. A lot of times when I have teeth that are kind of angulated in a way that would suggest possible ectopic eruption or eruption into a place of another tooth, I'll evaluate with a 3-dimensional X-ray. And sometimes I can tell 3-dimensionally where that's situated, if it's more palatal versus more facial, and how it's sitting next to the root. When we're just taking just a normal pan, it's hard to differentiate where those teeth are and if those things will erupt properly. And then if you ever notice that those premolars are in that position and there's a lack of room, the chances of them uprighting themselves and coming into place go way down. And so even just opening up a little bit of space for them so they have the ability, when teeth have space, they find that space. 99% of the time they'll find that space. It's just a matter of making sure that they have it. So hopefully that answered it a little bit. You're never going to be 100%, but at least it gives you a little bit better idea.
Dr.
Great.
Bell, there was one question in the chat if you would be willing to share your PowerPoint
Yeah, by all means.
with our group so that Nancy can send that out, or we can send that out afterward. That would be great.
Yeah,
And
no
then-
problem. Nancy, I think did I send that
Yeah.
out to you?
I have it.
Oh,
Thank you.
Okay. Yeah.
Yeah.
So
Perfect.
Nancy,
Wonderful.
feel free to send that out.
Thank you. Yeah. And Dr. Jenny Oliphant has a question too.
Yeah, please.
Okay. Jenny, do you want me to help you? Do you need to unmute? Let's see. I'll try to unmute you.
And while we're waiting on that, Nancy,
Yeah.
Dr. Bell, I just have to share with you, and I do share this with others from time to time, but I'm one of those statistics that as a young child, I had really crooked teeth, and I was always afraid to smile and was quite shy. And after I had orthodontics and got my braces off, it really did, as exactly what you said, is it just gave me a whole bunch of different confidence that I didn't have as a young child with really crooked teeth. So you are
Absolutely.
spot on with that.
Yeah. I had one patient that I was it wasn't the one that you guys saw in the video, but a patient that every time they came in would not smile with their teeth, very bubbly girl, but everything was lips closed. And so when we finished treatment, she was beaming ear to ear, showing her teeth. And I asked her if I could post a picture of her on our social media, and she agreed to that. And so when I went to tag her, I saw her profile, and I was able to go through some of her pictures. Not one time in the history of her social media, and she had years and years and years, family photos, out with friends, sporting events, anything like that. Not one time did she have a picture on there of her showing her teeth.
Oh, gosh.
And it was sad. It was sad. And then anything that I've looked at, because I followed up with her, anything that I look at now, I don't think I've seen one without her showing her teeth. And so it's really, really cool to see.
It's a big deal. Dr. Oliphant, I don't know if
Yeah.
okay, go for it.
I don't know. It wouldn't let me unmute myself.
Yeah.
So thank you very much. This is a presentation I've been looking forward to hearing. Dr. Crespo and I have been working on the oral health integration for a while, and orthodontists are our next group.
Yeah.
And I want to know, how do we reach them? We are working really hard to understand where we could ask some orthodontists some questions. We have some questions about some oral health integration and engaging orthodontists in the larger conversation of adolescent health.
In terms of trying to get a hold of local orthodontists, probably is going to be something that we could, or you could reach out to the local study clubs, because all of us kind of in the area are a part of those. And in terms of getting all of us here, otherwise, I mean, I don't have a problem if you wanted my number and I can reach out to other people if you had questions, and getting orthodontists together to talk about things, if that's what you're curious about. Otherwise, I don't know if I answered your question or fully understood if you were looking to contact us, or if you were looking at trying to set something up where the orthodontist in the area would talk about hygiene, or how we are integrating hygiene into our treatments.
Oh, well, we have lots of ideas about what we want to do.
Okay.
But accessing orthodontists has proved to be quite challenging, actually. When we want to talk to them about the integration between oral health and adolescent health. And so this is just having you on the screen is a huge step in our direction. And so I appreciate you saying I could reach back out, and I'd
Absolutely.
never heard of the study section. So thank you very much, and we will be in contact.
Yeah, no, absolutely. And I've done stuff like this in terms of lunch and learns and come out to places. My wife's a pediatrician, and I'm gonna end up probably going over to Centricare to give a talk like this to some of the pediatricians, so that they have an idea of what we're looking for as well. So if they identify anything, that they can send people or recommend going back to their dentist to talk more about that. So yeah, by any
And that's
means.
exactly what we're trying to push. I think that in the public, we're still experiencing this. Orthodontics is a nice to have, not a need to have.
Right.
And of course, insurance doesn't help us in some cases with that. But
Yeah, insurance is always the weak link in it.
Yeah. Thank you for that. And I was going to say, Dr. Bell, I took a lot of notes, and
Yeah.
this is medical dental integration, and Dr. Oliphant was talking about that as well. But I'm looking at orthodontia in terms of airway obstruction and breathing, skeletal positioning of the jaw, sleep disorders, headache, fatigue. I mean, there is such a crossover. This isn't just about, we do have beautiful smiles with orthodontics, but this really is a medical dental integration profession.
Absolutely.
I
And
learned a lot. Thank you.
good. Yeah. It's always fun to talk to my wife
Yeah.
about all the medical sides of things with dealing with young individuals, and then how our things integrate, because they do. They
Yeah.
come hand in hand. We talk about preventative treatment in orthodontics. They talk about preventative treatment in medicine and things that you can do. Sometimes there's a gap there though that needs to be kind of bridged. And so I think Dr. Oliphant was kind of hitting on some of that in terms of trying to bridge that gap in integrating those medical doctors, those dentists, orthodontists in the dental field, and trying to kind of get more of a fluidity, I would say, between
Yeah.
the two.
I think that's a great word.
Just one last quick
yeah.
thank you to Ebony for making this connection for
Yeah.
us. We really appreciate that. And thank you so much, Dr. Bell, for being here with us
Yeah.
today and for all the wonderful information. As you said, Nancy has your presentation, so we'll get that sent out. And we are at 1 o'clock, so we'll be
Awesome.
respectful.